Now, Professor Dario Rahelic. What?
It's very difficult to pronounce it.
Dario
Rahelic.
Rahelic.
Yes.
Yes. We speak about remission of type 2 diabetes, myth or reality. Russia? He is from Russia.
Thank you very much, Mr. Chairman. Dear ladies and gentlemen, once again, right now I'll speak about remission of type 2 diabetes. Is it myth or reality? Unfortunately, sometimes we usually think that it's just reality, but I'll try to point out that it's not maybe just reality, it could be a myth as well. These are my disclosures, and these are facts. So type 2 diabetes is a chronic and progressive disease. There is no doubt, and affecting more than 500 million people worldwide. And we have to emphasize that despite the modern therapies, modern technology, majority of people with type 2 diabetes and even with type 1 diabetes cannot achieve good glycemic control. Many people have established chronic complications in the onset of diagnosis. This was understanding of pathogenesis of type 2 diabetes 20 years ago. 20 years ago, we thought the most important thing is just insulin resistance and also beta cell failure. But insulin resistance, it means decreased glucose uptake and increased hepatic glucose production. On the other side, impaired glucose secretion due to beta cell failure was another issue, and only those two pathophysiological mechanisms were emphasized as the most important. Today, we know it's much more complex than it was 20 years ago, and we know that it's not about insulin resistance, it's not about beta cell failure, but also it's about CNS, altered fat metabolism, incretin deficiency, enhanced glucose reabsorption, and also many other pathophysiological mechanisms which can explain the pathophysiology of type 2 diabetes. On one side, we do have insulin resistance. We do have beta cell dysfunction, but also we have impaired liver production, increased liver production, and enhanced renal reabsorption of glucose. And there is no doubt that BMI is connected with diagnosis and the relative risk for diagnosis. And we know that type 2 diabetes is a progression. The type 2 diabetes progression is multifactorial challenge. It's not just about glucose, it's not just about resistance on insulin, but also on many other things. And for decades, there is a debate, is diabetes remission possible? It is important to emphasize there is no consensus definition what means diabetes remission. And I could ask you, I could ask myself, what does it mean diabetes remission? We know what means remission for leukemia. We know what remission means for cancer or malignant disease. But also, on the other side, we can ask ourselves, what is diabetes remission? And there is so many advices, and there are so many guidelines how to achieve good glycemic control, how to avoid type 2 diabetes in overweight and obese people, how to avoid progression of prediabetes to type 2 diabetes. And you can see it here that there is no doubt that weight loss can, at 12 months, can increase the remission rate. So if somebody will lose more kilos with low calorie intake, with high protein diet or some other diet, no matter, but the remission rate will be between 10 and 54%. But also, what is reality? What is realistic weight loss goal? And you can see it here. just with diet, with non-pharmacological measure, we can lose between 5 to 10% of weight. With cognitive behavioral therapy, up to 10%. With medication, we have learned from previous studies and from the previous session, even up to 25%, not just 15, but up to 25% with tirzepatide in SURMOUNT-4, which was presented at EISD last month. With endoscopic procedures, up to 20%. And with bariatric surgery, up to 45%. But on the other side, do the patient's expectation correspond to reality? We would like to lose our weight, we would like to lose 5, 10, 15, or 25% of our weight. But still, is it reality or not? And I will not go into details, but since 1976, when Professor Bistrian and his collaborators reported that very low-calorie, protein-sparing modified fast allowed for insulin elimination and could, in obese people with type 2 diabetes, could eliminate insulin and also could decrease the insulin resistance. But on the other side, gastric bariatric surgery nowadays, it's even more efficient in weight loss. But bariatric surgery has long been recognized as a potential treatment. But we have to be aware that only few centers who can achieve and also good results with metabolic or bariatric surgery, and also it's not affordable for many people in all our countries. For example, in Croatia, we are 4 million people. It's nothing in comparison to Egypt. But we have only 2 or 3 metabolic or bariatric centers with very few bariatric surgeries per year. So from that perspective, we cannot achieve good control and remission of type 2 diabetes. And these are mechanisms of bariatric or metabolic surgery. We know there are classical model or mechanistical model, which is restricted food intake and also cause malabsorption. But also the current model, which is more physiological because it's altered gastrointestinal signals to brain, endocrine signals, neural signals, but also signals to other tissues like pancreas or liver cells as well. There are so many clinical trials, there are so many reports which confirm that bariatric surgery is efficacious. And one of the theory, according to twin Taylor or Taylor twin cycle hypothesis during chronic overconsumption of energy, like you can see it here, the excess carbohydrate is removed by lipogenesis. And lipogenesis will cause fatty liver. And fatty liver disease is one of the main causes of type 2 diabetes and one of the risk factors for cardiovascular disease. On the other side, also the accumulation of fat in liver promotes the lipogenesis and also insulin resistance. But when we talk about mechanism of bariatric surgery, on the other side, you can see here that blood glucose level returns to normal within 1 or 2 weeks after bariatric or metabolic surgery. Previously, we thought it's just because of gastric regulatory hormones, like incretin hormones, but right now, it seems that it's secondary. And normoglycemia is achieved by another mechanism. And you can see it here, despite of current or previous theories, today, deacylglycerol, the product of removing one of the free fatty acids from free glycerol, for example, triglycerides, rapidly decreases in concentration, and suddenly cells are left with the normal choice of fuel, either glucose or fat, depending upon needs. So from that perspective, cells are starving. From that perspective, that's the reason why in bariatric surgery or in weight loss, no matter, HbA1c is much better, and glucose control can be achieved very quickly, even within 1 week or 2 weeks, and can be stable within several months or years. But after several years, you can see slow increase in body weight, no matter about the metabolic surgery. We do have some pre-surgical predictors of success. Younger age, shorter duration of diabetes, less than 5 years, non-use of insulin. So it's people who are taking oral medications or oral anti-hyperglycemic drugs, with better glycemic control and greater baseline visceral fat area. So almost healthy people. So with good glucose control, with younger age, with non-insulin usage, and also with shorter duration of diabetes, less than 5 or less than 10 years. So that's another issue with metabolic surgery. It's another issue in the term of remission of type 2 diabetes. But another issue is also a consensus what means diabetes remission. And consensus report under the auspices of American Diabetes Association from 2009 proposed 3 categories of remission: partially, when glycemia was below diagnostic threshold; on the other side, complete, when glycemia was below the diagnostic threshold without pharmacological therapy for 1 year; or prolonged without therapy for more than 1 year. Do you agree with this definition of type 2 diabetes remission? Well, I'm not quite sure that we can say that this is the appropriate definition of type 2 diabetes remission. And look at this. This is the definition of remission of type 2 diabetes according to ADA. People who have less than 6.5 HbA1c, a duration of 1 year. Complete, 5.7 or less than 100 milligrams per deciliter for at least 1 year with non-medication, and with metformin or with no medication, less than 6.5% of HbA1c. Is it diabetes remission or good glycemic control? We can ask ourselves. I believe that this is a good glycemic control. It is better definition than type 2 diabetes remission. And this is the definition of complete remission. Complete remission. So people no longer having pre-diabetes, neither diabetes, with HbA1c below 6.5. It's not complete remission. It's just good glycemic control. What about people who have HbA1c between 5.7 and 6.4 or 5, according to American Diabetes Association criteria, or 6.0 to 6.4 according to European criteria for prediabetes? So those people are considered as people with no diabetes, but they still have prediabetes, and we cannot talk about diabetes remission. No matter about HbA1c, but also about glucose control. On the other side, we have to emphasize the issue of HbA1c as per se, because HbA1c can be increased in iron deficiency, in impaired erythropoiesis. What about altered hemoglobin? What about glycation? What about anemia, destruction of erythrocytes? What about assays and methodology? ADA supports use HbA1c below 6.5 as generally reliable and the simplest criterion for diabetes remission. But from that perspective, HbA1c below 6.5 cannot be considered an indicator of good glycemic control, neither criterion of diabetes remission. Because long-term efficacy of diabetes remission on cardiovascular events, other chronic complications or mortality are still unknown. We have to ask ourselves, is that type 2 diabetes remission? Is it remission of disease or disease reversal? Is it realistic? I don't believe this is a realistic picture. And you know that it's not, Mr. Bean, at least not in reality. That's the reason why I also believe that there is no diabetes remission. Is some person who is overweight or obese, after losing weight, no matter metabolic surgery or non-pharmacological measures or with pharmacological treatment, and we do have efficacious pharmacological treatment, as we heard, and very promising in the future, but after discontinuation of treatment, they will weight gain again. After metabolic surgery, after several years, they will again gain weight. But I don't want to be so pessimistic. We have to looking at the future at least a little bit optimistic. And I like my country, as you already noticed, and this is the real island from my country. In middle Dalmatia, in middle part of Adriatic coast, we do have island in this shape. And every single Valentine's Day, they're showing all over the world this photo. And majority of people, they do not know, is this reality or is it myth? This is not myth, it's reality. This island really exists, and I hope that you will visit Croatia and you will visit this island at least from seaside coast. But when we talk about myth and reality in type 2 diabetes remission, we know that in the moment of type 2 diabetes onset, the 50% of beta cells are diminished. Previously, we thought that they are diminished due to apoptosis. Right now, we know that they are not diminished due to apoptosis, but their function is diminished, and we can modify disease in the future. There are so many possible interventions. There are so many ideal interventions which would directly address key elements of disease progression, not just about glucose control, not just about insulin resistance, fat accumulation, fatty liver, not about just beta cell function, but also cardiovascular risk, weight, and diabetes complications. But on the other side, we have to stress that natural history of type 2 diabetes is also progressive, and it has therapeutic consequences. And it depends. When type 2 diabetes is, onset of type 2 diabetes is very important, and also for the future therapy. And there is no doubt that weight reduction is crucial for the consequences of type 2 diabetes. But it seems that redifferentiation of beta cell could be the road to the future therapy of type 2 diabetes, because today we know that those beta cells are not, they didn't die due to apoptosis. Their function is diminished due to beta cell failure, due to glucotoxicity, lipotoxicity, but also due to dedifferentiation. And redifferentiation could be the road to the future therapy of type 2 diabetes. And it's not just about genetics. It's also about epigenetics, environment, phenotypes, maybe new population. What about climate changes and also environment changes? What about endocrine disruptors? But when we look at the future, sometimes we are surprising ourselves what is behind the wall. But for us, as clinicians who would like to do something good for our people with diabetes, is to achieve good glycemic control, to avoid chronic complications, and to achieve this. Long life with no complications. Dear chairpersons, dear ladies and gentlemen, thank you very much for your attention.